As you see, it is there in the word, the nurse itself. So N stands for to nurture a learning and development culture that encourages personal and professional growth. Then you'd like to upskill them by providing courses and programs to enhance the skill set of nurses, which we are doing now. And we'd like them to be respected so that they feel valued and recognized for the contribution they are doing in the society. And we would like to strengthen and boost their confidence and capabilities to enable them to navigate their roles with authority. And eventually, we like to empower them and give the nurses a stronger voice in the healthcare policies and practices. So this is Skills for Med vision for nurses in India. So as we have been seeing that we've started this webinars, and we've always been thinking, what is that we can do for our nurses who are the heart of our hospital, who are the backbone, and who are working tirelessly by the bedside of the patients. Then we thought that we should, empower them, give them the knowledge and skills. As you all know, knowledge is power. So that's when we started this initiative called Empower, Nursing Empowerment. And webinars is one of the initiatives. The other initiatives like we provide blogs, we give YouTube videos, and these are and these free webinars we are doing. And these webinars, the main focus of these webinars is one skill. If you have all noticed that every webinar we focus on one particular skill and also the implementation of that skill. So that is the focus of our webinars which we're conducting weekly. And I just like to quickly go through our learning pyramid. If you see at the base of the pyramid, you have the basic courses like professionalism, etiquette, communication, infection prevention control, and patient safety. These are the courses which should be taken by all the healthcare workers who are working in the hospital. So we are calling this Frontline Warriors Foundation course. It's a one-day course. And then we have nurse courses specific for nurses. Again, these are one-day courses, which are the fundamental course for the nurses, where we do the basics. We cover the nursing assessment and the daily routine tasks which we do for the patients and documentation, and so certain basic skills we cover in this course. Then we have our advanced medical surgical certification course, which can vary from 3 months to 12 months. There we focus on the bedside nursing skills. It depends on the hospital, like what are the time they can allot for the nurses to be trained. So we can do basically all these courses, we can do tailor-make it to the hospital and based on their needs. Then we have our nursing career advancement courses. So those nurses who've been with the hospitals for many, many years, senior nurses, they can do these courses to advance their career. This is, we have the training of trainers course. This is again a 3 months course. It's hybrid. It is, both online and offline. And we cover all these topics. During this training of trainers, we give them all the modules which we cover for the nurses, and they take this to their staff. They train their staffs with whatever inputs we have given. Then we have our infection control nurse course. We are very proud to say this is in collaboration with the 𝐂𝐬𝐬, the consortium of accredited hospitals, accredited healthcare organization. And this course actually is based on national and international guidelines. And it's a very comprehensive course. It covers all the topics which the infection control nurse should know. So once you do this course and be certified, you can very well be employed as an infection control nurse. You can register now if anybody is interested in this by scanning the QR code, or you can go to 𝐂𝐬𝐬 website and search for the infection control nurse course under the courses. Then you can register there. This is about our ICN course. Then we have launched our linked nurses courses for hospital infection control. We already finished one course, which is very popular, and there's a lot of demand for that. And the next course is coming up on 29th of August. It is completely an online course, a one-day online course. It's from 9 a.m. to 5 p.m. And the course fee is 1,500. And this again we are doing it in collaboration with 𝐂𝐬𝐬. So anybody who's interested in registering can contact us. And we have our other specialty courses, the labor room nursing upskilling program and the emergency room upskilling program. These are for the nurses who are already working in the emergency room and the nurse and in the labor room. It's just to upskill them to enhance their knowledge and skill in that in their area. For any of these courses, so what I've given you is a very brief outline of what we are doing. So if you want to know in detail about our courses and what is that we offer, please contact Ms. Chandralekha, who's our nursing training manager, on 91508 or you can visit our website and you can put your queries in that. So today's webinar is going to be on mastering IV fluids, the essentials of infusion and IO chart. I think this is one area where all of us need to, have, though we've been, in the field practicing nurses and doctors, we always have, doubt in this area. And it will be really nice to hear from Dr. Parivalvan Rajavelu, who's a consultant surgeon, Sundara Medical Foundation, and the founder of Skills for Med, who's going to talk about how to master IV fluids and what are the essentials we should know about infusion and IO chart. I hand over to Dr. Pari to take over the session. Thank you all so much for patient hearing.
Good afternoon, everyone. I'm so glad that so many of you have turned up for this course. I know IV fluids is always a pain point, however experienced you are. And at the outset, I want to put a disclaimer that I am not going to talk very complex things about IV fluids. As a surgeon, I look at very basic things of replacing fluids and leave the more complex therapy to the medical people. So, but for a nurse and a junior doctor, what I'm going to say is going to be very, very important because these are the building blocks on which IV therapy will be used in any hospital. So with that sort of disclaimer, let me start the slides. Right. As customary, we will first start this thing with a poll where we will be sharing our work experience. The poll is not about testing your knowledge. It's about your work experience in this particular field of IV therapy. So let me just start the poll. Right, I'm just going to launch now. There are just about 5 questions. I request all of you to just jump in and answer this question. We'll give a couple of minutes for this poll. All of you should be able to see the poll on your screen, so you can choose one correct answer. As you can see, all these questions are just related to what you encounter in practice. So it'll be a good representative learning from all of us about our practical problems and difficulties we face in IV therapy. So I encourage all of you to answer these questions. People have asked for the poll link. I'll paste it in the. Not able to paste it. Another 30 seconds more. All right. Another 10 seconds. Okay. I'm going to end the poll and share the results with you. So you'll be able to see the results in your screen now. See, basically the first question was, what is the primary fluid you use for initial resuscitation in a hypovolemic patient? Majority, 3/4, 75% said it is normal saline, 20% have said it is single lactate, and a small minority have said it is dextrose water. And we will look at, now we will get the answers of these in the webinar. How often do you encounter difficulties accurately assessing a patient fluid status? Again, 50% frequently, about 30% occasionally, never 1%. I really admire that person. And rarely about 17%. And what challenge do you find most significant in managing fluid therapy in a critically ill patient? It's sort of spread out all the four. I think all four are problems: monitoring and adjusting the balance, managing electrolyte imbalances, deciding between the different types of IV fluids, integrating fluid management with other treatments. The fourth question is, do you routinely use any specific guidelines or tools? Majority, 2/3 of them, they use standardized protocols and guidelines, and some, about 10%, use decision support tools, and again, 25% rely on clinical judgment. And what is the common complication? Fluid overload and edema is 60%, electrolyte imbalance 20, dehydration 11, and organ dysfunction like renal failure is about 10%. So very interesting. So it looks like, we, our challenges are quite significant and we are somehow coping. So let's get back to the presentation. I'll stop the share and stop the poll as well. Just give me a minute. Yeah, there we are. Okay, so let's get in the presentation now. Okay, the agenda today is I'm going to first talk about fundamentals and principles. Guru Raj, you have raised your hand. If there's anything, you can ask me now. Otherwise, questions will be at the end of the session. All right? Is anything urgent? All right, thank you. Right. So let's start with the agenda. So I will first touch upon the principles and fundamentals of IV fluid therapy. Not, we have all sat through the physiology class post lunch. So I generally, was in the library, not attending those classes. So I won't bore you too much with that. Only relevant stuff. Then we'll get into the core of the talk where we talk about fluid management, how to go about it, and finally, how to use that input-output chart effectively. So the fundamentals, it's, we know the importance. It is fluids are essential for cellular function. It maintains the homeostasis, prevents complications. And by understanding, it guides us in our clinical decision making. And overall, if we understand this better and treat the patients better, it leads to improved patient outcomes. So to start with, we all know that almost 2/3 of our body is fluids. In the women, it is slightly less, about 55%. In the men, it is 60% of fluids and 40% solids. So among the fluids, we have 2/3 is intracellular fluids. Yeah, 2/3 intracellular fluids, and it is inside the cells. and 1/3 is outside in the extracellular fluid. And this extracellular fluid is in two compartments. One is the interstitial fluid and the other is the plasma, and majority, 80% are in the interstitial. So the other way to look at it is this diagram at the capillary level. So we have the intracellular fluid that is within the cells, which is 2/3 of this 60% of fluids. And then you have the interstitial fluids. Majority of fluid is outside the cells of this extracellular fluid. So in which these cells are bathed, and the 20% of it is inside the blood vessels. So if you see the fluids and electrolytes have to get from the plasma into the interstitial fluid and then between the interstitial fluids and the cells. So this is how the fluid exchange happens at the cellular level. Now there's another way to look at it. So when we take in fluid, then what it happens is it enters directly into the plasma. Whether you take it orally or you give it IV, it ultimately ends up inside the blood vessel. So, and then it crosses the capillary membrane here and enters the interstitial fluid, which is around 11 liters, right? And then there is this lymphatic system which drains interstitial fluid back to the blood vessels, right? So that is also there. And then from the interstitial fluid that is here, it enters into the cell membrane, and that is this exchange. So this is how the intake happens. From the time you give it either IV or oral, it ultimately has to enter inside the cells. And as we saw, majority of fluid is inside the cells, which is about 28 liters of fluid, for an average 60 kilogram human being is inside the cells. Now, this fluid has to also go out, and it goes into the interstitial fluid, and from there into the blood vessel, and then the output happens by way of the kidneys, the lungs, our stools, sweat, and the insensible loss happening through our skin all the time. So this is how the fluid comes out of our body. So this is gives a basic understanding about the distribution of fluids. And this is what I was talking about. The lungs exchange oxygen and carbon dioxide. It goes through the interstitial fluid into the intracellular fluid. And then the gastrointestinal tract, all the nutrients and ions enter into the cells through the blood vessels and finally into the interstitial fluid and to the inside the cells. The output happens in the reverse way. All the water, ions, and nitrogenous waste are excreted by the kidney. So this is the basic, right? So we understand that the interstitial fluid is the sea in which the cells, what we call, you can compare it to the ships. So the sea is also salt, right? Similarly, our interstitial fluid is also contains a lot of salt, and in which the cells are bathed, and the blood vessels are the pipes which actually take the nutrients, oxygen, carbon dioxide, and other nutrients into the cells. So this understanding, overall understanding we should have about the fluid therapy. The other important understanding is the predominance of electrolytes in the various fluids. So if you see, this is the extracellular fluid outside the cells, both the interstitial and inside the cells, sodium and chloride predominate. Whereas inside the cells, intracellular, it is the potassium, phosphate, and proteins and magnesium, which is predominated inside the cells. So outside the cells, it's mostly sodium, chloride, and bicarbonate. So these are the cations positively charged, and these are the anions which are negatively charged. So this understanding is also important. Another important understanding you should have about fluid electrolyte balance is the concept of osmosis. Again, all of us read about osmosis in our science class in school. So you need to pull it out of our back of our heads. It is a lot of cobwebs will be there. So basically, it's very simple. It is process by which water molecules pass through a semi-permeable membrane from an area of low solute. Solute is the solids, right? Low solute concentration to an area of higher solute concentration. So the water will move where there is higher concentration of solutes to balance the water in both the concentration in both the compartments. So this is to equalize the concentration of the dissolved particles on both sides of the membrane. Why are we talking about osmosis? As I told you, the cells are bathed in this fluid, interstitial fluid, and this interstitial fluid can sometimes become hypertonic if the salts become more. Sodium, potassium, all those things, if they become more commonly sodium and potassium, but others very rarely, magnesium and phosphate and other things. But hyperkalemia, hypernatremia causes the cells to shrink and get dehydrated. On the other hand, if you do not have enough salts, like in hyponatremia, elderly, it is very common, then it becomes hypotonic and the fluid gets into the cells, it becomes swollen, and sometimes they can burst also, cause lysis of the cells. So both these are abnormal. No, you don't need to want to have an hypertonic solution in the interstitium, nor do you want to have an hypotonic solution in the interstitium. What you want is an isotonic solution where the cell membrane is the semi-permeable membrane. So you want the solute concentration to be the same in the interstitial and inside the cells. That is normal. So this is very important concept to understand. So with that background, what is disturbing this homeostasis? No, the body is in a stable state that is called homeostasis. So when there is fluid deficit, if you don't take enough water, or if there's excessive sweating when there is fever or heat stroke, acute gastroenteritis causing vomiting, diarrhea, burns where the skin integrity is lost, diuretics causing more of excess urination, postoperative patients who are unable to drink water, and we are the cause here. Improper IV fluid management, there can be fluid deficit. Fluid overload takes again excessive water intake when the kidneys are failing, hearts are failing, liver is not working properly, certain endocrine diseases, and again, we work on both sides, right? We can cause fluid overload and we can also cause fluid deficit. So remember this, when there is a fluid deficit, the salts will increase and it becomes a hypertonic solution, not good for the cells. If there is fluid overload also, the cells will drown in this and rupture. So both you have to avoid, and that is why fluid and electrolyte treatment is very, very crucial. Now, when you look at fluid balance, you always have to think about two things. When you see a patient for the first time, what is the past imbalances and what are the ongoing losses or gains? So the past is deficit or excess of fluids that is accumulated prior to the current assessment. Patient comes to the emergency department with, say, gastroenteritis. Patient already had that for a couple of days, and has lost a lot of fluid. So take into consideration what they have lost in the last couple of days. That is past. The ongoing is the current rate of fluid loss or gain that continues to affect the patient's fluid balance. So it could be, maybe you put a Ryle's tube and there is a lot of drainage through it, or the patient continuing to have diarrhea. So those are losses. Or you're giving a lot of fluids in a patient with heart disease and the fluid is accumulating, or sepsis. So these are all ongoing things you need to also keep in mind. So the imbalances always are either past or ongoing. And if you look at the past, I already told you, dehydration due to prolonged diarrhea, vomiting, or inadequate fluid intake, or fluid retention due to heart failure, renal impairment over the past few days before they come to the hospital. So we'll take that into account. Ongoing could be diarrhea, vomiting, nasogastric suction, excessive sweating, maybe because of fever, or increased fluid intake, IV fluids, enteral feeds, or medications that affect the fluid management, that cause the fluid retention, and also diseases that cause fluid retention. So this is something you have to always keep in mind. And the ultimate goal of fluid electrolyte treatment is maintaining homeostasis. You have to keep everything in balance, the acid-base status, the electrolyte status, the fluid status, everything. So basically, you keep the fluid electrolyte balance in both the intracellular and extracellular compartment. And very, very important is to maintain that isotonic state in the interstitial fluid. So we can do that only by altering the intravascular space, because we have access only to the vessels, right? Orally or through the IV, we can put water into the blood vessels. But our treatment should be such that it doesn't affect the isotonicity of the interstitial fluids. That is the important concept. Now, roughly, water intake should be equal to water output, very simplistic way of looking at it. And salt intake should be equal to salt output. And you avoid any imbalance between salt and water so that the solution which you give should also be isotonic unless otherwise indicated, right? So that is also important to remember. Now let us get into the replacement options. What are the options we have to replace fluid? Now I'm talking about IV fluids here. And we have both crystalloids and colloids. Basically, crystalloids are solutions with small molecules. They will easily pass through the blood vessels and cellular membranes. It mainly used to correct fluid imbalances, and they could be isotonic fluids or hypotonic fluids and hypertonic fluids. An example of isotonic fluids are normal saline and lactated Ringer's solution. We also have colloids, which are solutions with larger molecules. They remain longer inside the blood vessels and expands the blood volume. This is very important in shock. We have natural colloids and synthetic colloids. Natural is human albumin. Example of synthetic is dextran. I will not be talking about colloids in this talk. We only talk about crystalloids. So we have 2 or 3 workhorses which we use all the time for IV fluid therapy. The first is the normal saline, which is sodium chloride dissolved in sterile water. So 1 liter of 0.9% sodium chloride has 154 milliclins of sodium and equal amount, 154 milliclins of chloride. So it is an isotonic solution of NaCl. And we use it for volume expansion, rehydration, mixing drugs, and indicated in hypovolemia, shock, diabetic ketoacidosis, and in treating hyponatremia. The second workhorse is Ringer's lactate. It is a much more complex solution which has sodium chloride, sodium lactate, potassium chloride, calcium chloride in sterile water. And this is the salts which are therein. Sodium 130, potassium 4 milliclins, calcium 2.7, chloride 109, and lactate 20 milliclins, which is converted to bicarb in the liver. So basically, this is almost having the concentration of electrolytes as plasma. It exactly mimics plasma. That is why it is so important to use it in burns and in people who have lost a lot of fluid. So it is used in rehydration, fluid resuscitation, and replacement of electrolytes. Indication, as I said, burns, trauma, surgical patients, and metabolic acidosis because of the bicarbonate. Okay, so these are the 2 workhorses. The others can be classified into hypotonic solutions. We have the 5% dextrose and water. Though the dextrose actually makes it isotonic, by the time it reaches the cell, the glucose is taken out and it becomes a hypotonic solution. Dextrose 5% with half normal saline and then half normal saline. These are hypotonic solutions. Hypertonic solutions are either 3 or 5% sodium chloride and 10 or 25% dextrose, which you use in hypoglycemia. So, these are the hypertonic solutions which you use. So these are the common ones you use. I'm not getting into the more, uncommon ones. Now let's talk about the basics of replacement. As I told you, as a surgeon, I'm more interested in replacement. And I think as any common conditions in the hospital, this is the first thing you have to deal with. The more complex condition, always you can get expert advice. Because if you do this, the patient will be alive for the expert to come. So that's important. So when you calculate the daily needs, first you talk about the fluids. A very simple calculation is about 30 ml per kilogram per day. So for example, a 70 kilogram adult at 30 to 35 ml will be somewhere between 2 to 2.5 liters or 2100 to 2450 if you want accurate figures ml per day. So 2 liters to 2.5 liters is the rule of thumb. We need to replace for a 60 to 70 kilogram adult. The other way people do is, especially in pediatrics, they have this 4-to-1 rule. The first 10 kilogram is 4 ml per kilogram. Next 10 is 2 ml, and every additional kg or 20 is 1 ml. So for example, if you want to calculate for an adult, first 10 will be 40. Next 10 will be 10 into 2 ml, that is 20 ml. The remaining 50, that is 1 ml per kg, it'll be another 50. So it'll be around 110 ml per hour. Okay. So either way you look at it. So you have 2 to 2.5 liters, which you need to give the patient, and you give it at the rate of 100 ml per hour. This is the rule of thumb most of us will use for an average Indian. So this is what we use in most hospitals. Now, if you look at the electrolytes, the sodium is 1 to 2 millicoulombs per kilogram per day. Chloride is almost the same, 1 to 2 millicoulomb. And potassium is 0.5 to 1 millicoulomb per kilogram a day. I am not getting into the other electrolytes as I told you. So, for most 90% or 95% of the cases, if you focus on these things, you would be okay. Unless the patient has got complex medical problems, which is causing other electrolyte imbalances. So remember this, 1 for sodium and chloride, 0.5 for potassium. Half of the sodium requirement is the potassium. So this thing should be in your mind and you cannot forget it. So the ideal IV fluid regimen will be actually ringel lactate and dextrose with half normal saline. So if you look at, you say give it at 100 ml per hour, you will be giving 2,400 ml over 24 hours. This is what the patient will get. Gets about 260 milligramms of sodium, about 25 to 45 milligrams of potassium, calcium 3.78, chloride almost equal, lactate around 40. So this again is pretty good for most adults. And though the electrolytes, sodium and chloride are more than the requirement, 1 ml per kilogram will be around 140. Even if you take it at 2, it's 140. It's slightly more, but most adults will be able to handle it. But most hospitals, I find, and also in our hospital, what we do, we alternate ringel lactate with normal saline. That's what we do. So you can do it. For most normal individuals will withstand it, but keep in mind this thing that you are giving almost 300 millicoulombs to 330 millicoulombs of sodium chloride, and the potassium which you are giving is very low. So you need to, if the fluid therapy is more than a couple of days, you need to replace sodium separately, apart from this regimen. Now you need to dissolve KCl in normal saline, alternating pints, so that they get that 0.5 milligram per kilogram, which is 60 kilogram adult. It should be at least 30 to 40 millicoulombs of potassium they should get. So why is this? Why are we giving such high concentration and getting away with it? That's because a normal adult, the functioning kidney will eliminate sodium chloride, but we need to supplement potassium. But giving a lot of salt in most elderly patients and disease patients will cause problems. So this is not an ideal regimen. But why I'm highlighting it is, this is a regimen which is used very commonly in most hospitals, and it will lead to excess salt. So better option will be ringel lactate with half normal, dextrose with half normal saline. Okay, so this is in general, and then now we get into input and output monitoring. Now traditionally input output is monitored every 24 hours, 7 a.m. on one day to the 7 a.m. the next day. So this will be done by 3 nurses or 2 nurses, depending upon whether it's a 12-hour shift or a 8-hour shift. And each nurse will be doing individually for that particular shift, and the handing over should be very good, because the doctor will come only in the morning, and you have to make sure that all 3 shifts are tallied and presented to the doctor in a proper way. So this is a pictorial representation. The nursing shift starts at 7, and it may be 2 or 3 shifts, and the period of measurement is over 24 hours. Whereas the doctor may come anywhere between 9 a.m. to 11 a.m. And he'll see the previous 7 a.m. to 7 a.m. input-output chart and then calculate it. This is for normal patients. I'm not talking about sick patients, right? Most post-op patients who are stable patients in the ward, this is what happens. Okay. Now, if you look at the fluid balance chart, we have the intake, which is charted, output, which is charted, and the day is totaled, and the balance, whether negative or positive, is noted. So this is the purpose of the input-output chart. So you write all the things which are the patient is intaking. That is, it could be IV fluids, it could be total parenteral nutrition, oral or through NG tube, and then the output, urine, gastric, other things, all that are total, and the balance is taken, right? So if you take the intake, the type of fluids, as I already pointed out, can be either crystalloids or colloids, and it can be either oral or parenteral. Now, with output, it could be drains, tubes, stools, stoma, or if the patient has got fever, you got to account for more sweating and insensible loss. Gastric, if the patient has got vomiters or NG, and of course, urine output. Okay, so basically, what is the volume? We already know. The patient should get around 2500 ml for a 60 kilogram adult, and the output should be roughly about 1 liter to 1.5 liters of urine and 300 ml of stools, and evaporation loss will be around another liter. So in the output chart, the evaporation and sweating is not charted. Okay, so you will get about, if you get about 1500 to 1800 output, you're okay. You have to add the evaporation and sweating to that. And if you are given 2.5 liters and your charted output is around 1.5 to 1.8, you're okay. So that is what, looking at the input-output chart means. And when you look at the balance, it should be always zero. It will never be zero. It will be either slightly negative, slightly positive, but it will be very close to zero. So this is the ideal situation. Okay. So also every day when you look at the input-output chart, as I told you, you also have to look at the past balance. So what is the past balance in the previous days in which the patient has been in the hospital? Is it positive or negative? And how much positive or negative? So that also, leaf through the previous input-output chart and look at the balance in the last few days, and then review whether what is the orders which you have to give for that particular day. So ongoing losses, that is the previous 24 hours only is in the chart, which you will see, the current chart. But you also have to go back to look at the past thing. And then what the patient is going to lose the next 24 hours is what you have to predict. That is the ongoing losses, and this will depend upon the patient's condition. Okay, so the doctor's role is compare the input-output, write the new order based on the patient need, review on the 24 hours for a stable patient, more frequently in severe conditions. So I think I'm almost at the end of this talk. So we only talked about replacement, and it won't be good to end this talk without talking about the other aspects of IV fluid management, but we don't have time for that. But I'll just put in the algorithm. So the first question when a patient encounter patient is the patient hypovolemic? Is he behind fluids? Is that the question you have to ask? If the answer is yes, straight away get into resuscitation. This is what's happened in the emergency room, trauma. We are looking at hypovolemic patients. Yes, we will resuscitate. We'll give them fluid bolus up to 1.5 to 2 liters of fluid bolus till we are satisfied that we have corrected the hypovolemia. If the patient is not hypovolemic, mostly in the wards, can the patient meet their fluid or electrolyte needs orally? So because oral is the best route. If they can, then you replace it orally and the matter ends there. If they're unable to meet it orally, then you have to get into IV fluids. So when you're giving IV fluids, there are 3 things to look at, as I already pointed out. Existing fluid or electrolyte deficits or excess, that is what is the current. Ongoing losses, and so that is the past. I told you, the past is the existing fluid and electrolyte deficit. What has happened in the past? Check ongoing losses and estimate amounts. And finally, in complex patients with renal failure, patients with other hyponatremia, hyperkalemia, these sort of people also in the ward. Here, the redistribution is not as simple, so it will be more complex. So you will need to get expert advice to manage these patients. So this is the overall algorithm. This is based on the NICE guidelines. So asking about the patient's hypovolemic status, whether they can take orally, And if you're giving IV therapy, to look at the existing and past losses, ongoing losses, and then look at the patient's condition, see whether there are redistribution issues or other complex issues, and get expert opinion. So that's, ladies and gentlemen, is my talk. I'm going to give you 3 scenarios and see how well you got it. So patient presents severe dehydration to 3 days vomiting. Past imbalance is 3 liters. Ongoing, what you predict is an ongoing vomiting and diarrhea will be another 1 liter per day. So how much of fluid will you give? It is be 3 plus 1, isn't it? So past loss plus 1. So you need to give 4 liters you have to plan in addition to the daily requirements. Okay, so the example 2 is about post-operative patient with the patient who's not taking fluids. Here, he has been hydrated well, and you're only going to look at the ongoing losses. Okay, so then it becomes very easy. So your normal 2 to 2.5 liters will take care of this patient's problem. But here is the third scenario I told you, where there is complex issues. Here, chronic heart failure with fluid overload, excess fluid of 2 liters over the last 2 days, and then continuing to have fluid retention. So this becomes a bit complex, and it's not as simple as adding 1 plus 1. You need to monitor the patient closely and adjust the fluid electrolyte balance. So let me end with 10 steps for managing fluid balance. So use an IO chart to assess the patient's past 24-hour balance. Consider the total past imbalance, past 24 hours and the previous days. Anticipate and plan for the ongoing losses. Choose the correct IV fluids. Now, we spoke about the 2 workhorses, normal saline, Ringer's lactate, and also the hypertonic and hypertonic solutions. Choose the best one for that, your patient. Choose the appropriate route. Is it oral or IV or an enteral? Write the order in ml per hour. The nurses will convert it into drops per minute. Use the fluid bolus and rapid correction of electrolytes as needed. This is for complex patients who are either having fluid deficit or electrolyte imbalance. Then you need to correct it. Write orders for output monitoring. How often do you want the output to be monitored? It has to be continuous or hourly. You need to write proper orders. Otherwise, no point coming the next morning and say, shouting at your nurse saying they have not done the input-output properly. Your order should be very specific. Review as often as necessary. As I told, stable patients, you may come once in a day, but other patients you have to monitor closely. And finally, adjust as required and write fresh orders, and this cycle goes on. So that brings the end of my talk. Thank you so much for your patient listening. Any questions, I'll be glad to answer. You can put it in the question answer session, box, or the chat box. If you want to talk and ask me a question, raise your hand and I can unmute you and you can talk. Okay, so I hope the was useful for you, but any questions we can do for a few minutes. So let me look at the question answer box. I hope the screen was visible. Somebody have told you that screen not visible. Okay, drops per minute and all that. We're having a separate webinar on that. Okay, somebody has asked how many drops a minute for 100 ml. We'll talk about it in that. Child is just asking cumulative input-output calculation. See, the cumulative input-output calculation is more for the ICU, where the ICU charts are designed in that way. I was talking about a normal situation in the ward where you look at the input-output charts are only for 24 hours. Even then, it is very important for you, especially when if the patient there is an ongoing loss. For example, in the ward right now, we have a pancreatitis patient with necrosis, and he's in the ward. Every day morning, I need to look at the previous, because he's taking in a lot of fluid and not putting out that much of urine output. So I need to look at the cumulative, increase, calculate it, and then write the orders for the present. So you need to do it, and it's based on a patient-to-patient basis. How to manage rigor in IV fluids? Just stop them for a few minutes. I think the quality of IV fluids has actually increased quite well. I know still there may be some areas in our country where it is a problem, but mostly in the cities, we are we're not getting so much of a problem. This is because of the pyrogens inside the IV fluids which causes rigor. Mostly it can be just stopped by just stopping the fluids for half an hour, waiting for that to settle down. If the patient's got fever and rigor, then you may have to give paracetamol to bring it down. Colloids, as I said, I have not spoken. Girija is talking about colloids. In emergencies, in trauma especially, colloids have no role. Okay, the role for the immediate, that is the primary, what is called the initial resuscitation of trauma patients is only crystalloids. So, because that causes immediate volume expansion. And if at all you need to give colloids, you give blood, not any of the synthetic colloids. Synthetic colloids, as you know, the research in synthetic colloids has been totally sullied by vested parties. So there's a lot of talk about it in the 70s and 80s when we did our MBBS, but then proven to be wrong. So crystalloids are still the mainstay for emergencies. Where we have to control the IV in case of overload or renal failure? I don't understand that question. Where we have to control? It's basically to control the input, basically, and relying on diuretics may not be that good, especially for chronic kidney disease. I think there are nephrologists here in the listening to me. You can actually, unmute and answer that. 1 minute, let me get into that. Patient with diabetes mellitus, ideal fluid, a pre-op, where we start them on ringer lactates or normal saline, not any of the dextrose solutions. So that is about the question answers. Nobody's raising the hands, I think. No. 2 people. Priyanka, you can unmute now and talk. You have to unmute yourself. Do you want to ask any questions? And Guru Raj, you also raised your hands. And Bilal. So I have asked you to unmute. You can talk. Now, let me get into chat. Okay, Arif, you're the nephrologist here. How do I do that? 1 minute. I can unmute you. Yeah, you can unmute and you can tell your point about magnesium, Arif. I think it's important.
Hi, can you hear me?
Yeah, I can.
Okay. No. What I'm saying is, it is an important thing to check it. Unless the magnesium is corrected, potassium losses is hard to match. So that's one thing, at least, once a day, when you have lots of losses, either nausea, vomiting, or diuresis, whatnot, just check it. That also prevents the other arrhythmias too.
Okay. That's a good point because we don't do it routinely. So I think that's really, good point.
Right.
Yeah,
Then another, sorry, Pari, another important point is normal saline is misnomer. It's not necessarily physiologically normal. Anyway, so the important point, you said, that's a very good thing. Abnormal saline with a ringer lactate is a very good point. Whatever the fluid you give, try to keep the chloride level in the fluid less than 112, that prevents the renal failure. Some people keep the normal saline going forever,
Yeah.
and that actually causes renal failure and acidosis. So that's one thing. And the key is a small secret I'll tell you. If the patient's body chloride is more than 105, switch the normal saline.
Okay. Give normal saline, you're saying? Or
No,
stop it. Stop it.
Stop or change it to lactate ringer solution, half normal saline.
Yeah, I think that's one point I actually wanted to know. I made that in the middle because routinely normal saline, because it's called normal saline, people tend to favor.
Yes.
So that's the reason I put the ideal thing where we have to mix it with just water.
Yes.
That's the dextrose half normal saline. So then
Right.
keep the sodium and chloride levels lower. But
Yeah.
most often we would most hospitals will give normal saline and ringer lactate alternator.
Right.
So, but still patients handle it most of the time. As you say, these stray patients who suffer from it, we don't actually catch it. So that's
right.
Yeah.
Anyway, I need to congratulate you. It's a very, very informative presentation, Pari. I'm so thankful for your special interest. And, I'm sure, you may know, I'm sure if the liver patient comes, albumin may not be a bad choice
I
too.
actually didn't get into all those things because
Okay. Sorry.
Thanks, Adam. Adam is actually my classmate and a very leading nephrologist in the US. Thank you so much for your time listening to me and giving your expertise. Thank you so much.
Thank you, Pari.
Thanks. Okay. Any more questions? We'll answer. Otherwise, we are going to stop here. If the patient is a known case, okay, we did that. Session on single-use device. Yeah, I think Shailaja has been asking that. A session, I don't know. Maybe we can use on tools and tips and tricks. We'll probably include that. Yeah, we've been asking that for a long time. Burns is a separate topic by itself. No, we would do it as one webinar, and probably I'll call one of my burn specialists to do that. So that's, I think we've come to the end of it. And
Pari, one second, Pari.
Yeah, tell me.
Okay. Please make sure, for me, I ideally weigh the patient myself standing weight every day, in spite of all the balances, what is documented, not documented. Weighing the patient standing up, if possible, that will add lots of value to it.
Weighing the patient, yes, okay.
Weigh the patient every day, standing weight. I do it myself, but most of the time.
Right, that's a point. I think we don't do that. So, point taken. Thank you. Thank you so much. Bilal, you've been raising your hands and I unmuted you. You want to talk? No? Okay. Right. Thank you so much, all of you, for your patient listening and staying till the end of the session. And I think few more things, few more announcements. Next webinar is on mastering nursing rounds and reducing patient calls. So it's focused on nursing. And this is one, again, pain point for nurses about rounding and how to reduce the patient calls. So we thought we'll talk about it. So that is on 9th of August, same time, 2:30 p.m. So that's the upcoming webinar. And this is our QR code for the WhatsApp group. I'll leave it on for a minute or so that you can scan it and join our WhatsApp group. Our announcement for various courses, webinars, and also I think you're planning some educational material on the WhatsApp group also. It's in the pipeline, but it's not happening. Hopefully from August that will happen. So please join the WhatsApp group. I'll just leave it for another 30 seconds. And thank you for all your appreciation in the emoticons. It really gives me the high.